everyone. This is Ahmad Fahmy here and Bill Trattler. I just wanted to, in the beginning here, I just want to really just say how much of an honor it is to be lecturing with Dr. Trattler. He does not need any introduction. Dr. Trattler's been just a phenomenal physician and ophthalmologist. He's coming to us from Florida. And I'm joining in here from Minnesota. And Dr. Trattler, I just wanted to say thank you for being a part of the Eyes on Dry Eye meeting. We're going to take on a really interesting topic here, and welcome to the program. So.
Of course. Well, I think he brought me on because he wanted to bring some sunshine and warmth up to Minnesota. So I'm hoping I'll bring up some good weather, which I'll do my best.
All right. Great. So these are just the housekeeping disclosures for Dr. Trattler, and this is in my disclosure slide. If you guys notice that, this caught my eye, that it's apparently, Bill, you practice in what looks like pretty much like heaven and nice environment. So I saw that this morning. I took a picture of my neck of the woods. So this is what it looks like.
Oh
here.
my gosh. What is it? Is that sand? What is that? I haven't seen something white. Oh no, it's snow. Okay. I've seen that before.
Yeah, so we're gonna probably do some sledding right after this. So you're welcome to join us, by the way. So.
Beautiful.
All right. So our course outline, really the thought behind this talk was to really tackle the idea of what do we do with these patients that are sometimes refractory to our initial treatment offerings. These patients that might have been referred to us from our respective colleagues in the community, or patients that we've started some treatments on. We expected them to get to have some subjective improvement, but they just haven't really responded well to initial therapies. So this is that talk about, well, why is these patients still symptomatic, and trying to kind of narrow it down as much as possible to some of the main things that are ocular comorbidities that we found over our careers to really be, sometimes the culprits as to why patients are still not feeling very well after we've treated them, and then looking at, different features of kind of, we'll kind of start talking about just kind of a really high level view of what it is that we're trying to treat, and try to develop a protocol which is reliable, which is not too complicated, that we can refer back to in patients that have severe level dry eye, but also just all the patients across the whole spectrum. And so it's a kind of a big task, but I think it'll be fun to kind of talk through that. And then just kind of thinking about some of the, we have a lot of treatments that alone can be, one of the main challenges with ocular surface disease, is just how many treatments there are. And then just understanding what are some of the potential side effects, and how do we balance some of these treatments, multiple treatments for patients that have multiple comorbidities. Again, just with that whole goal of trying to get that patient's quality of life better, and trying to get that breakthrough subjective improvement. And then again, just kind of identifying some of those main factors. So that's kind of the idea behind the talk. And then the cool thing about the virtual platform is that we'll talk about also whatever you want to talk about, because we'll have some nice questions in the chat, and kind of talk through some of these during the Q&A session. All right, so that's kind of the goal for what we want to kind of accomplish here. And so I'll start off here just kind of talking about our general or kind of basic understanding of where we are right now with ocular surface disease. We have, in my understanding, there's kind of some main buckets that most patients land into. There's the evaporative aqueous deficiency patients. We know that ocular surface disease, from work of the DEWS report and many other fantastic groups, that this is an inflammatory problem. And then there is often a simultaneous obstruction component that we have to, sort of address all of these things. So those are sort of four main characteristics of ocular surface disease. And it helps to kind of refer back to that when we are trying to figure out how to treat these patients. Bill, what are some things that you kind of think about, just kind of in general terms, as to what is your basic kind of approach and protocol that you've been able to kind of refer back to, and kind of use as a launch pad to, think through your treatments for some of these patients?
Well, I think the what you're bringing up are four great topics of what causes dry eye, but they're all overlapping, right? So when you have aqueous deficiency, a lack of moisture, it causes inflammation. But maybe also the inflammation also leads to reduced production of aqueous tears. And then when you have evaporation, like there's less the moisture, even though you're making tears, they're evaporating. Again, there's not enough moisture on the eye, so you get inflammation. But then again, inflammation can be a risk factor. So I mean, all these things go across. I'm always thinking through all these things. They come with my treatment plan. What's the most important for this particular patient? Should I lean more towards trying to fix the evaporative part first, or go more towards aqueous deficiency first, or treat the inflammation first, or maybe do a couple things? So this is a great overview. I love this way you put this together.
Awesome. And the cool thing about what we do is that there are a lot of moving parts. And so there's so many things that are, ocular, factors and conditions and systemic conditions and extrinsic factors that are really moving all of these, things. So multifactorial is a word we've heard a bunch of times, but really the neat thing about it is digging down into what's causing the main, keeping the main thing, but also identifying all these peripheral things that we often see in treating these patients. And we know, from Sjogren's patients, this is a conjunctival image showing, inflammation and infiltration of T cells in patients on that left side compared to the normal conjunctival, surface. So we know that this inflammatory problem is probably going to keep on brewing if it's not addressed appropriately. So that's kind of a nice, kind of a basic framework to refer to when we're thinking about some of these patients. So at the end of the day, we just want patients to feel better. And if we really want to figure that out, how to get that patient to feel better, one of the things that's been really helpful, for me is to try to understand how, densely innervated the cornea is, where we are dealing with the part of the body that is the most sensitive, part of the body. And so sometimes we see these patients that have some central involvement or corneal neuropathic pain. Bill, what are some, kind of some caveats or some kind of advice that you might have for us to try to understand, how to identify these patients early on, and what are some of the key features that you see in some of these patients that might have corneal, kind of neuralgia, corneal neuropathic pain?
So these are tough, and I do have a couple of patients in my practice I take care of, and it's really difficult because you're trying to figure out what's going on, because their eyes may look relatively normal but they're having complaints of discomfort. You're talking about neuropathic pain. So somehow the nerves are reacting to sensations that aren't there's no stimulus. They're just having the nerves are firing and causing problems. So I think it's a small bucket. Obviously, we can go into more detail. I love this slide overall because it does explain that our patients in general, when we're younger, we have great sensation, and patients often complain of foreign body sensation, burning of their eyes, and irritation. But as patients get older, many patients may go more towards that their eyes feel good, even though their corneas are very, very dry looking with staining and rapid tear film breakup time. But they say their eyes feel fine. It's really the subjectiveness of blurry vision and fluctuation of vision as their main symptom. So it's just a great topic to cover. I'm glad you brought this up.
Awesome. Yeah, it's one of those things where we have to figure, if there's any disruption in those corneal nerves, there's attrition of the nerves, which sometimes happens, and then there's lack of sensation with also these patients that have some kind of aberrant regrowth of those corneal nerves, or aberrant kind of feature to it that makes these, as you exactly like you said, kind of sort of misfires, and these patients can have some central involvement. So trying to figure out where these patients are is really important in identifying these early. I've had a couple of these patients that have really tough, central component. And I think probably one of the worst things we can do is say, well, clinical picture looks good, so I think you're fine, because some of these patients really struggle with their quality of life. Just like you said, I mean, these patients can sometimes have, more depression and things like that. So
Absolutely.
yeah, so I'll just start by one of the things I wanted, we have a bunch of different cases that really highlight some points. This is a patient that I saw few weeks ago that had really some asymmetric disease on her right eye, just had a lot of, irritation type symptoms, really, a lot of dryness and irritation. And, one of the main things in her case is that, she'd been treated for, she has kind of this hemifacial spasms that we can't really figure out what's going on with it, but she's been treated with some injections and blepharospasm. And so these injections basically were causing a lot of exposure, and her blink was really kind of an incomplete blink. The point I was really trying to make with that case is that, oftentimes we look at a slit lamp and some of these things that we might consider maybe a peripheral problem that maybe, another, colleague might be taking care of is something I really don't want to focus on. But in her case, it's really the most important thing to focus on, because you can really throw the kitchen sink at the patient like that. But if they really have a problem with their blink associated with her treatments elsewhere, that's the main thing that I really, sort of sometimes we need to focus on. So incomplete blink or, exposure is really one of those main things that can, again, cause these patients to be symptomatic, even though we're treating them with some typical treatments. Along the same lines.
Absolutely.
Yeah. And along those same lines, this is conjunctival chalasis. Bill, what are your thoughts on what is your threshold for intervening with conjunctival chalasis, and when do you do that, as far as kind of how it looks in the slit lamp and what the patient tells you?
Right. I'm going to go back to our last patient, because I've been treating this one patient exactly like I described. Blepharospasm, our oculoplastic person has been giving Botox, and she had so much exposure. I mean, her cornea was just nonstop stain. So we actually had to end up doing Procara, an amniotic membrane to the ocular surface. She had punctal occlusion, patching of the eye, and eventually she's turned the corner after about 6 weeks of treatment. And so those patients that have that exposure that you're describing can be tough, because like you said, the normal treatments, you put them on the normal treatments and they don't get better. And then you realize you really got to go much more deeply down to the different treatment options to get patients better. And also the oculoplastics held back on more Botox for a while, and that's helped turn the corner as well. But I'm glad you brought that one up. And then I'm happy to talk about conjunctival chalasis, but it's such a good topic. I just wanted to jump in that. As far as conjunctival chalasis, it can be a problem, and there are a number of treatments that are available to that, surgical treatments. I still try to treat medically, because usually we can get patients treated medically. But it's really frustrating if it's really a lot of material that's overflowing. Sometimes it leads to exposure, just kind of like the other patient, where maybe they're going to need patching at nighttime, even patching during the day, and you can try different therapies. But there are definitely medical therapies that can be used before surgery, but occasionally patients will need to be sent for surgery.
Yeah. Awesome. I put this in here because I know everybody on this in this symposium basically has seen like the nasal and temporal conjunctival chalasis images, and one of the things that kind of grabbed my attention with this patient is that it was into that inferior kind of limbal area, and there seems to be some more association, more symptoms when it's kind of not just nasal and temporal in a lot of these patients. That same patient I was talking about earlier,
right.
Also had, I walked in the room and I was like, oh, beautiful long lashes. And I look in the slit lamp and I'm like, oh, well, those are not just your lashes there. So again, just what could be kind of a subtle finding actually could be contributing to the patient's symptoms. And this picture here just shows you that these eyelash extensions there's a lot of work that's been done to see if there's an association with dry eye disease and some of these eyelash extensions and the airflow to those patients. So again, the main points here is that subtle peripheral findings, although they might not be the main thing that's causing the patient's symptoms, might be still really contributing to it. And I just Dr. Don Korb really ingrained that in my mind, that really an incomplete blink is one of the main factors in meibomian gland disease. And we know that about 85% of the patients that have these type symptoms really are struggling with meibomian gland dysfunction. So this is a patient of mine that just has that incomplete blink. And sometimes if we're really just zeroing in on, the corneal surface or looking at other aspects of the exam, we might miss this, sort of incomplete blink. But those patients that have an incomplete blink also have likely glands that are just not functioning as well as they're supposed to be. So, so these are all, kind of just little important things. And one of the things that sometimes happens also in my clinic is that, ectropion can be really obvious in some patients, but sometimes a subtle ectropion is not really something that jumps out at you. And so this patient here obviously has a nasal ectropion, and really thinning that beam down and comparing eyes. I go back and forth all the time in my clinic these days, just to really figure out if that's something that can be contributing to that patient's symptoms. And here you can see that nasal ectropion, and then there's a little bit of that puncta is also a little bit everted there. And so sometimes,
Yes.
What are your thoughts, Dr. Trattler, on, epiphora? So that's one of the main symptoms that we see all the time in dry eye disease. What's your threshold for having that patient maybe do, like a like looking at the nasolacrimal duct and potentially maybe if there's some kind of an obstruction there? When do you usually send those patients off to, sort of investigate that more?
That's a great question. Every patient comes in thinking that they need to see the oculoplastic specialist, they need probing, but most actually have meibomian gland dysfunction and they have just evaporative dry eye. That's the vast majority. And what I'm looking for is actually the tear volume. So one of the things you look at is how high the tear volume is, because if there's true blockage, you're going to have an overflow of tear in many situations. And so that's what I often use. So if I don't see a large amount of excess tears, I'll just treat them for MGD, for meibomian gland dysfunction, and try to get their dry eye better. And if they can solve it that way, then we've avoided, probing and a procedure. But sometimes we don't, and then I refer out.
And so, so I blepharospasm, again, it's one of these things that really has to be very carefully titrated. And so if we swing the pendulum, the other, sort of end of the spectrum is there as well. There's been a lot of great work in clinical studies that have looked into patients that have secondary blepharospasm and how that increases their ocular surface disease symptoms. And so some of these patients can really have some association with SLK. And this is just a presentation that was actually in 2014. This was shared with me by our oculoplastics, one of our oculoplastics partners here at Minnesota Eye, Dr. Bill Lippum. And we sort of really started looking more into this, and 18 out of the 19 eyes in this study showed partial resolution of their signs, and 84% showed complete resolution of their surface findings. So it was PEK and inflammation of the conjunctiva. So if there's too much, of course, if there's too much sort of involuntary blink, that can really also affect how these patients feel. And so I have a very low threshold. As soon as I see that, if I see it in clinic, to have these patients referred, having known also that from that first case that I showed in the presentation, that it really has to be very well titrated, because exposure can be one of those things that can really also lead to those symptoms. But I just wanted to show this really, kind of a neat little video that Dr. Lippum again shared with me. This was a patient that has blepharospasm, and you can see there he's got the typical rosacea patient as well. He's got these telangiectatic vessels and facial rosacea, and he's kind of tearing up there on his left eye. And then after his injection, you can see that his blepharospasm is much better. He's much more comfortable. And this patient, his osmolarity was really way out of his range. And then after just one treatment, his osmolarity scores and inflammatory eyes were much better. So again, not to sort of over sort of state kind of blepharospasm, but that's one of those things that really has to be very carefully titrated with our ocular surface disease patients. Bill, one of the challenges I mentioned earlier is there's so many treatments out there, and this is kind of a really old list of some of the things that we have. There's a lot more there. As far as just your approach to treatment on patients, throughout the whole spectrum, give us your advice on that.
Right. Isn't it just artificial tears? Do we need anything else? No, I'm just joking. Obviously, obviously you need more than artificial tears. So actually, I find that my probably the medications I use the most are topical steroids, because I think topical steroids are pretty universal. They'll help with evaporative, they'll help with aqueous deficiency, they reduce inflammation, and it can work very nicely. I usually use a short pulse of 3 weeks or so, 4 weeks. And the patients, usually twice, like a steroid twice a day for 3 or 4 weeks. And that is one of the, it's not alone that I use it, but that's usually very helpful. It's one of my mainstays. And then it depends really if I'm leaning more towards aqueous versus meibomian gland dysfunction. If it's more evaporative with MGD issues, I'm going more, and blepharitis, I'm going more with like a hypochlorous acid spray a couple times a day to kill the bacteria that are causing, impacting the oil gland secretions, and a heating pad. I find that works really well. And then if I need to go the other direction, we have a variety of different agents that we could add, like the different topical cyclosporins that are FDA approved, lifitegrast, and other treatments as well on the aqueous deficient side. So also could use punctal plugs. And we have a lot of options for us.
And so, can you kind of comment a little bit about the orals, azithromycin, and kind of how do you decide, I guess, oral azithromycin versus doxycycline, or kind of using topical versus oral azithromycin?
So the good news is that there are many studies that show, not many, a number of studies that show that azithromycin, which is easier to tolerate, you need to take less of, is as effective as doxy for rosacea and for MGD when you're using it. We know that topical azithromycin is wonderful, but sometimes it's not available. It's a harder drug to get. So you can use oral agents. I find that I don't use either of them very often because there are some side effects more for doxy. So I end up going more with hypochlorous acid spray, which I find, with time does a really nice job for MGD, plus heating pads. And then we have therapies like, all the different heating therapies that we have. Like at our center, we have both LipiFlow and Tear Care. There's so many others that are out there now too that can really help patients. So I've been using the orals less, but there certainly are options for our patients.
And then when you have these patients on, just to kind of help me kind of figure out what is, as far as the long-term picture, do you have patients on it when you start them on orals? Do you have them sort of ongoing, or do you have them use it for a few months and then taper off of it, or go on and off? What's your usual protocol?
So for orals, again, I usually do a pulse of 2 or 3 months is my typical. I'm hoping that the orals will help, really bring the situation to a better point. So again, it's usually we're treating for MGD or thick oil secretions. I try to get the eye better. But again, hypochlorous acid spray works really well. It's really easy to use. I use that very often. I also use, depending on their symptoms, again, we're going to use the warm compresses, and if patients are really symptomatic, then again, we're going to talk more about the actual heating therapies, because that in and of itself can really make a big difference for these patients.
Awesome. All right. So one of the things that we always try to figure out is okay, what are all the things that we can do, and then who's the patient that we really should be treating, and a lot of times these workflow type kind of flow charts really help us. Of course, everybody you recognize this is all the algorithm from ASCRS that really what I really liked about this is it kind of broke down ocular surface disease visually significant versus non-visually significant, and trying to anticipate these and treat these, identify and treat these patients before surgery. And one of the things I really like about this diagram is that top part there, that basically just kind of that look, lift, pull, and push. It's really something that if I had that in my head with every ocular surface disease patient that I see, there's really we probably don't miss that many findings there. So looking at the blink, lifting the lid, pulling the lid, and then pushing on the meibomian glands to see what kind of expression you're getting, doing those things consistently on every patient is really, really helpful. So it's really important for us to think about comorbid ocular, problems or eye problems in patients that need cataract surgery or need corneal surgery. Really, what should be our way to really, figure out how much treatment these patients require heading into surgery. And I'll just, ask you to please comment on, this really pivotal and just a terrific study that really helped us think about this properly, for refractive surgery patients. Bill, if you could give us an idea, kind of the nuts and bolts of this clinical study.
Oh, sure. Really, Genesis was back in about 2008, 2010. We wanted to see how common or prevalent dry eye was in patients scheduled for cataract surgery, and our guess was about 15%. Because we see patients every day coming in for cataract surgery, and most weren't really symptomatic. And it turned out when we did this multi-center clinical trial that it was actually much more common than we thought. Even though patients were asymptomatic, they didn't have burning or stinging of their eyes or irritation, they actually had significant signs on the cornea. So they would have, you can see the high prevalence of positive corneal staining, including central corneal staining, which could affect our topographies and our IOL masters in patients scheduled for cataract surgery. They had a rapid tear film breakup time and very commonly. And so it was really a shock that it was so common. And eventually we started presenting the results about 2011 or so, 2012. And I guess I got a little bit behind in getting it published, but did get peer reviewed eventually. But we spread the word pretty quickly and people became aware of this. But just really tells us that you can't just base your concern about dry eye by their symptoms of, oh yeah, my eyes feel fine. That doesn't mean they don't have dry eye. It's actually much more common than you think it is. Maybe why they're coming in to see you for cataract surgery. It's not their cataract, it's actually their dry eye that's causing their vision to be frustrated, to be blurry. And the reason why I identify that is if you don't treat it, you can do beautiful cataract surgery and afterwards they're still unhappy with their vision because you didn't treat the dry eye part of their condition.
Exactly. Awesome. And then this is, I think, you're one of your patients.
Yeah, this patient has a classic case of keratoconus, right? Well, it almost looks like keratoconus. You see that in this topography, there's green above, which means it's a little bit flatter, and there's this red area below, which looks steep. And so there's inferior steepening, and this might qualify as keratoconus. But if you take a look, it doesn't look like classic keratoconus because up to the left, you can see that there's an area that's kind of moving, that shouldn't be there. Like usually keratoconus is really flat above and steep below, but you can see there's some steepening above as well. And actually this patient had dry eye. It was pretty obvious on Slit exam with fluorescein staining. So we treated the patient, and after a couple of weeks, the patient came back, and you can see the repeat treatment showed that the patient had very symmetrical astigmatism. So thankfully, we identified it and treated it, and we're going to obviously get a much better result with any type of eye surgery. And this shows us how important identifying and treating dry eye can be before for repeat imaging.
And that was only in 3 weeks of was topical treatment, just in 3 weeks.
Yes.
Okay. Yeah.
Right. So here's the important part though. So what we did is we cleared up the surface so that the tear breakup time got a little bit better. Some of the corneal staining got better, so got better imaging. It's possible that you bring it back another month, there could be even less astigmatism. Sometimes it could still even get better. But the key is that if after that you don't continue therapy and you just, okay, now we're ready for cataract surgery, do cataract surgery, then those are the patients that come back 3 or 4 weeks after cataract surgery saying, oh my gosh, I didn't realize that, I thought my eyes would be comfortable after cataract surgery, but now my eyes are really uncomfortable. What did you do during surgery that my eyes are I'm so unhappy? I'm seeing great, but my eyes don't feel good anymore. And it's because we really have to have a long-term strategy as well for dry eye in these patients.
Yeah, and it's really, I've experienced that just as well. Some of these patients can really wrongfully really associate the surgical procedure with, if you didn't, talk about, I think Dr. Donenfeld, kind of ingrained that in my head. If you don't talk about it before cataract surgery, it's probably going to be ingrained in that patient's mind that it was the cataract surgery that was really a causal factor, or the main reason why. So yeah, getting ahead of that is really, really important. And
yes.
This is a case that I'll go super fast through this case, so we can get to some of the other things in our discussion. So here's a patient of mine that I've been seeing for many years now. I inherited her care about 7 months after her initial cataract or her surgery. So this was her pre-LASIK topography on the right. This is the left. So I really didn't have any major issues, full, nice, healthy cornea on both sides. The decision was made to do LASIK. So 1 month post-operatively, and we'll focus on her left eye, and because that was the eye that was giving her most of her trouble. She's like, I really have to use lubricating drops all the time on the left eye. And in 3 months, after surgery, there's just some asymmetry in her visual acuity. And then 5 months after, she's switched from being a patient that was kind of like, hey, I have to use some lubricating drops sometimes, to being pretty unhappy with the result. And we see these patients, unfortunately, sometimes more, of course, than we'd like to. So this is a classic, case of this patient that has some higher order aberrations that are in some, need for a lot of lubricating drops, which is unusual, for most of our refractive surgery patients. And so what do you think should we do next here? A patient had LASIK surgery, has a little bit of residual correction, has to use lubricating drops all the time. And should we do an enhancement, LASIK enhancement, PRK enhancement, focus on, have her go to see a OSD specialist, or just monitor things? And of course, we know what kind of talk this is. So of course that the appropriate thing really was to zero in on, and that's kind of a big red flag, right? If patients need to use lubricating drops every hour, that's a big red flag, right?
Right, but they're not having any corneal staining. And so obviously it's a red flag, because normally you expect them to have some corneal staining if it's dry eye. They might have rose bangle staining or listening green staining of the conjunctiva. That's true. Some patients don't have fluorescein staining of the cornea. It could be more conjunctival, but I'm suspicious it could be something else.
So 7 months after, her procedure, early on, she was really, doing well. She was 20/20. Now she has, again, residual correction. And she starts to develop some anxiety. And 7 months after the initial LASIK surgery, she had enhancement in her left eye. And then she just 1 year after the enhancement in that left eye really became, very anxious, and just asked me flat out, am I going to lose my vision in this left eye? And so digging deeper into her, tear film lipid layer and doing some imaging, this is what her left eye looks like. So obviously, this is something that really we should have identified before doing any, procedures on this patient. One of the things, Bill, that I found to be really kind of a puzzling for me is that sometimes I'll see a patient like this, has 1 or 2 glands on the lower lid, and I look at the surface and there's no PK. And so there must be some healthier glands on the upper lids in some of these patients. But what is your kind of your protocol for making sure something like this basically is really identified? I mean, you did the study on it, so what advice do you have for folks out there that really have to identify these things basically before surgery? I mean, what are some of the protocols you've put into your practice to make sure this doesn't go missed?
Right. Well, I think the challenge is that some patients can actually self-compensate in some way. Like it may not be obvious. Their tear film may be okay. I mean, obviously we could see they have very, you might want to point out that there's very little meibomian gland left on this imaging, so they're probably not making much oil from the lower lid. Like you said, maybe the upper lid's making some, maybe there's some mucin also being secreted that helps keep the tear film somewhat stable. But clearly this patient's, at risk for just easily getting toppled over to being, having a poor tear film and having fluctuation in vision. And we know that when there's inflammation, that can lead to an increased risk for needing second treatments after LASIK, that the success rate for LASIK goes down and the increase for needing second treatments goes up because of, again, poor tear film, and there must be some inflammation making the corneal change power in some degree. Maybe it's just the epithelium, but so the key thing is, again, you're trying to do a really good preoperative evaluation. Don't currently include meibomian gland imaging as a preoperative measurement routinely. But if I did find someone who had obvious like MGD when I do push on the meibomian glands, which I do, then I would potentially screen. But I do exactly what you said before. I have the patient actually look down and look for scurf preoperatively. I am looking at the oil glands to make sure that they do produce good oils. and then just trying to make sure that the patients don't have any obvious dry eye preoperatively.
Awesome. So when we identified this, and you get the point by in the slide, there's a lot of things that we can do, for a patient like this. A lot of different, treatments, a lot of different options. And, she's a young patient. She's very active. This is kind of what we landed on. And I've been seeing her now for many, many years after her initial surgery. Now she's anxiety's a lot better. She's a patient that I have been doing in-office procedures every about 3 to 4 months. I find that IPL and expression, on these patients to be very helpful. And so we're doing, this is, sort of her list of treatments that we're doing. So, and I mean, she was really one of these patients that went from a significant amount of anxiety as to, what did I do here, to understanding that if she's, able to do some of these treatments. It's been over 10 years now after her surgery, and she's been doing well. Her quality of life is a lot better, but she has to do a lot of things to maintain that. So big red flag. Yes. She had kind of a soft endpoint with her refraction. 37 years old, no ocular pathology, mild, moderate nearsightedness. It's kind of a red flag when a patient during that initial refraction is not really having, kind of a sharp endpoint. A clear cornea, sometimes doesn't necessarily mean all is well, just like, Bill very eloquently mentioned. And then just, evaluation, pre-op, and then evaluation, reevaluate, if things aren't really going according to plan. And then Bill, what's going on here?
Well, what is going on here? It's an interesting patient, right? So there's a patient that came in and they got referred in and they just weren't sure what was going on. And you can see in the left image, there's a lot of these white opathies that look kind of like almost like, I know, what's the best? I mean, it looks like all different types of interesting images on the left. But then you look at the, actually put fluorescein in, which is the same patient with the fluorescein dye, and you can kind of see that there's some negative staining and some positive staining. And so this is some type of corneal condition or conjunctival corneal condition. So it's a puzzle. This is not normal. We don't expect it. So you can ask, I think there's a couple questions. So is this like, is that a dendrite? Is it HSV keratitis, or maybe it's zoster? Is it EBMD, or is it OSSN or CIN? And so that's our question. Any thoughts? And so that's the answer. Thanks for getting that. So these patients this is a really interesting case of OSSN or CIN. And besides having that, they also had some dry eye. And so that's why I brought that into discussion. But they can come in and with a staining, it can be suspicious. You can start to think, okay, I got to treat the dry eye part as my only therapy. But obviously with that irregular, this is a pretty advanced stage at this point. But earlier on, it probably didn't look as obvious. And so I just have to be suspicious for CIN. It's usually on the conjunctiva, but it can involve the cornea as well.
Yeah, it was really interesting when I first looked at this. I thought, well, what is that fungal infection doing mostly in the epithelium?
Yes, exactly.
So
yes.
What a really neat picture. Yeah.
Absolutely. And so then the therapy, the therapies change over time. And so just to mention, we're now using 5FU. We used to use interferon alpha 2B, but that's no longer in the market. So 5FU and pulse therapy topically works quite well for these patients and worked beautifully for this patient.
How long was it? Like about a six week course of the drops? So
yeah, surprisingly enough, in about 6 weeks, this patient cleared up. I think because it was mostly corneal. I see the conjunctival ones, especially when they're denser and thicker, can take many months, but it can be shorter. And interferon was, I know, worked really fast. In general, I'm getting more experience with 5FU, so I don't have the best knowledge of how long things are going to take with 5FU. I feel it's a little bit slower, but we'll see as time goes on.
Really neat case. One of the other things that can really be kind of a puzzle is limbal stem cell deficiency. So again, these are sometimes these patients that started some initial therapies, but they cannot kind of get rid of their foreign body sensation or kind of their recurrent erosion type symptoms. Limbal stem cells is they're really important for maintaining the ocular health and act like basically a nice barrier between the corneal surface and invasion by conjunctival epithelial cells. So they're a really important part of the ocular surface and the health of the cornea. And when that environment starts to get disrupted, we sometimes see neovascularization and sort of some corneal scarring. And the hallmark for this is this kind of vortex type of epitheliopathy, and kind of this vortex pattern epitheliopathy. And so these really neat little hallmarks or landmarks called the palisades of Vogt, with these little striations at the limbus. And sometimes these patients, when they're completely gone, that can be another sign of limbal stem cell deficiency. Some form of that, some amount of that is normal with aging, but and limbal stem cell deficiency can be different from one quadrant to the next. So it can be partial or it can be complete. But this is another one of those main reasons sometimes those patients are refractory to initial treatments. Another hallmark of this is that there's some thinning, epithelial thinning, that you can see on OCT in these patients.
Oh, interesting.
Yeah, and this is really just a study in 2018 that kind of really showed kind of the progression of this condition. And what really kind of grabbed my eye, you can see this vortex epitheliopathy, but it also kind of affected the corneal nerves in the nasal plexus. You can see as the condition progresses, you can see that there's basically corneal nerve attrition in some of these patients. And so I think this is a really pivotal one to kind of make sure it's on our radar. These patients, the most common reason for this is when we have patients come in with some kind of a chemical injury, contact lens, related type of an injury to the eye, or a chemical kind of a cleaning solution or something like that. And these are all, other kind of, primary and secondary etiologies, contact lens wear, or patients that have needed to have multiple surgical procedures. And it's important to identify this really early on, because until that problem is fixed, basically, or improved, corneal transplant for this type of patient really won't work. It's just not going to work, because if the limbal stem cells are really not functioning well, it's really tough to get a transplant to be successful for these patients. So yeah. What is your, Bill, how do you treat limbal stem cell deficiency in your practice?
Well, first of all, this is a great overview and great topic. I think that's really tough. This is one of the tougher conditions to treat. We try to treat medically when we can, but sometimes they may need type of surgical intervention where they can have some transplantation of stem cells. But the first thing we're going to do is, always I try to treat dry eye. So I'll put punctal plugs in to raise the tear volume. We'll use topical anti-inflammatory drops like topical steroids. These patients may benefit from amniotic grafts to help with more anti-inflammatory treatment, essentially with the amniotic graft, and that could help. Just trying to really supplement the tear film, trying to make things as healthy as possible, try to get the limbal stem cells that are available, try to repopulate and grow into the area where it's missing. But it can be tough, and sometimes you won't get enough improvement, and then they'll need to go on to a stem cell transplant type of surgery.
Awesome. So I want to go a little bit faster through. I really cannot do a talk with my respected colleague Bill Trattler without doing just this one last part here with an important epitheliopathy that we see so often. So I'll have you kind of talk through this one for us, please. Yeah.
Very so nice. So this is just one of the typical cases we see. Where we have a 76-year-old male with the cataract, and they come in, they get IOL master, and so. I started talking about this, a while ago, like a long time ago, that we can't tell with an IOL master or the biometry whether there's an abnormality of the corneal shape. And so that's why it's critical that all patients that undergo cataract surgery do get topography. That's been my standard for a very long time, and I think it's pretty much adopted by most people. And I really think it makes a big difference. And here's a great example. So this patient comes in, and the Ks are normal, axis length is normal, not that much astigmatism. We get the topography, which will show, which is if you go forward one step, and you see it's quite irregular. And so, what is this? I mean, obviously, it's not fair because you probably can figure out what it is pretty easily because you're an expert in this area. But also, We've had a chance to look at the slides together. So there's a patient that has EBMD, and it's a very interesting presentation of mapped out fingerprint dystrophy or epithelial basement membrane dystrophy. And EBMD can present in all different types of patterns and images. Sometimes you can have inferior steepening that can look just like keratoconus. I thought this was an interesting one because it's kind of a side area of steepening. And you can see this patient also has some dry eye as well. And so the nice thing is that we can identify this and treat this patient for their EBMD with an epithelial removal, allowed to repopulate over and let the eye heal over a couple months, and the patient can become a really good candidate for cataract surgery. So I think these are one of the interesting cases. So I do like to treat with a removal of the epithelium, wait 2 or 3 months, and then by that time the corneal shape has gotten better, the astigmatism is usually improved as well, and the patient can do really well with cataract surgery. If you were to go ahead and do cataract surgery first, they'd end up, with a very reduced best corrected visual acuity. And in some cases, while they may have somewhat of a cataract, you perform the epithelial debridement, smooth out the epithelium, and then they don't need cataract surgery because that was really the main reason for their visual loss.
Awesome. Awesome. So we've kind of, talked about a few of the main things that really can make our patients still kind of, symptomatic. And we really appreciate you joining us. Thank you so much, Dr. Bill Trattler, for joining me for this session, and enjoy the rest of this, everybody. And we'll see you soon. All right. Awesome. Thank you so much, everyone, for joining us for our really fun talk. Thank you so much, Dr. Trattler. I just want to move this along. We've got 3 minutes. So one of the things that I think is really important, we see all the time, is conjunctival chalasis. There's a lot of interest in the chat about what topical treatments might be available, but then also once a doctor of optometry, hands off that patient to ophthalmology colleague, what are some of the options that they might be, what are some of those options on your end for patients that are struggling with conjunctival chalasis?
That's a great question, and it's definitely a tough condition at times to really get under control. The 2 surgical techniques I'm aware of that are done in our area is one is doing an excision of some of that extra material and then placing an amniotic membrane down on the bare sclera, and then it heals over very nicely. Other doctors are doing a kind of a bunch technique where they're basically using forceps, kind of putting all that excess material in, using a cautery to cauterize off all that extra material, and you're left with this little linear, conjunctival scar, but it heals up very nicely and smoothly after about a week or so. So those are 2 techniques. I think they both are apparently effective, and hopefully we can treat medically and not need those surgeries.
Right. Yeah. So, I think one of the things that too we can miss in those patients that are just refractory to our treatment options is limbal stem cell deficiency. We kind of touched upon it a little bit. Can you please share again, some of your clinical pearls and how to identify it, and what are some of the things you found to be effective treatments for limbal stem cell deficiency?
Yes, well, I think that's, we see those, actually, that's not as uncommon as you might think. And when you put fluorescein stain in the cornea, sometimes you'll notice that there's these little whorls of epithelial irregularity at the limbus. And it could often I'll see it superior, but also nasal and temporal as well, or it could be 360. And when you see that, it's a sign that the limbal stem cells aren't functioning well. And if patients are maybe mild to moderately symptomatic, as far as discomfort, you can definitely treat them medically. And medical treatments will include punctal plugs, topical steroids, amniotic membranes can be very helpful to try to just help heal those damaged limbal stem cells. And with medical therapy, often we can get some improvement, and it's just rarely that we need actual surgical intervention.
Awesome. One of the other things that really, again, I was really happy to see, there's a lot of interest in when we talked about those patients that just have a central component or have neuropathic pain. And in my experience too, these can be really some of the toughest patients to try and to actually get them to have an improved quality of life. Again, can you kind of share a little bit with our colleagues? What's your experience in kind of, again, identifying these patients? And then how do you, treat these patients and take care of them?
Well, these can be tough patients to identify. Often they'll come in and they have the classic symptoms of dry eye, and you think they have dry eye, so you start the therapy of dry eye. You're giving them all different types of dry therapies, and they're just not getting better. And no matter what you do, you just can't make them better. And finally, you realize that they don't have any staining, their symptoms are unchanged, and then you're going to have to go down a different pathway to help these patients. So I think the key is really trying to diagnose them. And once you diagnose them, there's actually a number of centers across the country that are quite focused in treating them, because there's a lot of different things that can be done. And so I typically, I'm lucky I have Dr. Anaka Laura right around the corner from me, just 20 minutes away, who I send to in those rare cases. But they have to go through a whole stepwise approach. It's quite a difficult situation, but thankfully there are options for them.
Well, I know this was a really brief Q&A, but again, I just want to thank you so much for your time. I learned a great deal from you in our talk, and thanks again for being a part of the program.
Well, thank you for having me, and I love being part of this. I always learn from you as well, so it was great to be here.
Thanks so much.